proportion of people who were on typical or atypical antipsychotics, both in some cases, or neither, or in some cases unknown. So we had to drop those sites where you had no medication information, which is sad, but there was. So it's been published, as you all have known, which I'm very pleased with. We're all very pleased with. A lot of very hard work from those first few authors, and of course everybody on the calls who was helping us out as it was going along and doing all the heavy lifting. It is open access, so anybody can get that. Thanks to Paul for pushing that and for covering the charges on making it open access, because it's not cheap. But it's out there and it's ready to go. What we actually found, and I think most people have seen the bar graph, so I wanted to actually show the table just quickly. The hippocampus had the greatest effect size, if you will, in terms of p-value, but the actual percent of volumetric difference was in the lateral ventricle, which was also significant but in a different direction. So I was describing that as hippocampus is the most robustly affected, but the lateral ventricles are, in a sense, most grossly affected in terms of just case control differences. And in our particular case, the caudate and the putamen were not significant in the meta-analysis. If we looked at the moderator effects, which is worth looking at, basically duration of illness and age, which are highly collinear, of course, in our case, did seem to affect the putamen and the pallidum. And the proportion of unmedicated patients had an unexpected effect on the hippocampus effect size. Now, one of the challenges with these analyses, and I've had to explain this to almost everybody I've had to talk to about this, is that we're not looking at the effects of duration of illness on the putamen volume. We're looking at the effects of duration of illness on the effect size, on the difference between the putamen volumes in both cases and controls. So that's an interesting comparison. Yeah, basically, it's like basically the older your sample, the greater the effect size is going to be in the putamen. So, some quick lessons learned, because I know that that's an issue for all of us. Basically, our first one was we need to include as many analyses up front as possible. At first we were like, oh, well, should we really include all of these analyses? And we said, sure, let's just try it. That actually worked out well. And then in review, we discovered, of course, that we had left out a lot of covariates that the reviewers really want to see, and that would have made getting the paper published easier, and also possibly a little bit cleaner as well. So we're now doing covariate analyses on a site-by-site, individual-by-individual basis, as opposed to doing it post hoc as moderators, whenever possible. Sometimes you can't. And as a result, the cortical analyses that we're now doing are actually much richer. And also, never say die. More data keeps coming in all the time. Even though we said, oh, we're going to stop the data here, well, 3 months later there's another couple hundred subjects. So what are you going to do? We're not going to say no. But we do have to draw the line at some point. And we did, as of about a year ago, I guess, say, okay, we're not taking any more sites. So we actually have a whole bunch of new sites who've joined since then whose data was not included in this paper, which are here, actually. So the many of these are the original sites. We actually broke it up by scanner, so we have a number of sites that basically had, they count as multiple sites, even though they're just 2 scanners at the same location. So all of these folks have basically, I think, I don't remember if UPenn was included, in fact, in our original. All of these folks have joined since our last publication. Some of them are not entirely clear yet how many subjects they're actually going to be able to provide, and we actually have, this is Dan Stein showing up once again. He just contacted us a few weeks ago and says, hey, since I'm doing everything else in ENIGMA, I also have schizophrenia data. And we said, sure, absolutely. And then we also have discussions with a couple of other sites who may be able to join in and participate, but they're still figuring it out. And so basically we now have 26 data sites with several under discussion, and if all goes well, we'll have almost 3,000 patients with schizophrenia and quite a lot more healthy controls. The original groups that were participating had very closely balanced schizophrenics cases and controls. The newer groups, because they're not necessarily pulling from papers they've already published, they're just throwing everything at it. So we end up having quite an imbalance between the patients with schizophrenia and the healthy controls. We'll have to decide what we want to do with that as we move forward. So, as Paul says, we have quite a few secondary projects and from our website. This is actually our main paper that just came out. Lei Wang and Boris are running the subcortical shape analyses. basically, they were at a point where they were doing quality assurance, and they determined that they really have to do it two different ways. They have to do it on a site-by-site basis, as well as on an overall across-site basis. So they're still hammering that out. Esther Walton from Germany is running the cortical thickness and negative symptoms. They've actually gotten a number of sites to do the analysis, return the data, and they are, I'll show you some initial results in a minute. Dana, I'm never going to say your name right. Miss Dima. Dr. Dima is already, I always think of her as a sub-project of schizophrenia, but obviously you're not. So you'll be talking later about that. Nielce is running a sibling and first-order relative study. She's actually at a point where she's doing the cortical QA and subcortical QA scripts, because that, again, requires a great deal of development for the purposes of taking into account family relationships. And she's always looking for more. She's gotten a great response from the people that she contacted who have family data, but she's really interested in hearing from other people who are siblings and who have data sets of siblings and first-order relatives of patients with schizophrenia and imaging data. Roberto Ruiz and I think Nielce as well are running a first episodes repeated scans longitudinal analysis study. That's a little bit slower off the ground. Laura Kunders is looking at cannabis effects on structural measures. Again, all of these groups are, well, I think almost all of them are always looking for more participants. So I'm hoping at OHBM we can hang up lots of little slides saying, please, if you have data it's all interesting, please talk to us. And Sinead's obviously going to talk about the DTI secondary what I consider a secondary project, but of course is an outgrowth of DTI and schizophrenia together. So quickly, what Esther was doing with negative symptoms, now of course that's a real challenge. We all know that patients with schizophrenia have negative symptoms, but how they were assessed from every data set was very interesting, and they weren't necessarily assessed the same way. So there was a great deal of work put into harmonization of the clinical symptoms before you even get to the harmonization of the imaging data. But they figured out a way to do it. She's got so far about 13 sites with about 1,600 patients. They're literally just, I believe, trying to do a regression of the negative symptom severity against cortical thickness in particular regions of interest. So they're not trying to do the whole brain. They had targeted regions based on the literature and their understanding and their expertise regarding schizophrenia, and took it from there. And so far, they've been looking, they converted all of the scores, which actually uses Theo's conversion technique to turn PANSS scores into SANS scores, because they basically had a number of groups with both PANSS and SANS. So they had to look at SANS, and they were looking at the left and right medial orbital frontal thickness. This is sort of the forest plot showing they are at the moment finding a left effect in that you basically have decreasing medial orbital frontal thickness with increasing negative symptom severity, as I understand it. However, this is highly preliminary, and they expect that they're going to be hammering away on that a bit more to make sure that there aren't any other confounds in there that they need to take into account. So currently what the working group is doing is a cortical meta-analysis. So we've done the subcortical. As of last summer, we had used most of the ENIGMA scripts to do the cortical segmentation and QA, and we've got all those histograms. And if I was smart, I would have had all of those pictures to show you what the histograms look like, but it doesn't really matter. We know what we're doing in terms of the QA of the cortical thickness across sites. So far, 16 of our 26 have provided that QA, so we've gone ahead and identified the models to look at main effects of diagnosis across cortical regions. And those models are basically, we're using both thickness and surface area. We are obviously starting with the cases and controls, same as before, nothing new there. But then within the cases, that's where we're actually changing our approach and doing the individual regressions. And between Derek and Leanne and Theo, we've actually changed our scripts significantly so that analyses can be done even if the data is missing. Basically, the scripts will go around it if your site didn't collect that information, for example. It's much smarter than it was before. When we did this before, we basically had to use the lowest common denominator. Do most of the sites have this measurement? Then we will use it in the analysis. But now we can actually say, hey, we have 26 sites, 13 of them have premorbid IQ. We can use that. So we're looking at a group by sex interaction, group by age interaction. We can look at the effect sizes of the antipsychotic medication groups as we did before. But now we can do it within each sample. We can look at the effect sizes for associations with our chlorpromazine dosing, age of onset, duration of illness, your total symptom severity, positive symptom severity, negative symptom severity, the same thing on the other scores. Covariant, again, for age. Very, very, you can get much more complicated now than we could on the first pass. When, of course, with covariant for age and not covariant for age, because that's also an important question given the collinearity of many of these things. And then we're also looking at association with IQ, with it with controls within our cases and overall samples comparing covariant for diagnosis. That's a tricky one. We're going to be going on with that. So far, we've looked at 1 or 2 data sets, and basically, we're seeing so far that the overall effect size seems to be greater in thickness than in surface area, but that's just really very initial results at the moment, nothing going on there. We plan to examine premorbid versus current IQ. That's an issue within schizophrenia in particular. And many sites have used measures of premorbid IQ as opposed to current IQ. Other sites have used current IQ. We plan to add verbal and performance IQ, and of course, we're open for discussions because I know many of the groups are having to look at this. 4 sites have run the analyses so far, and we basically have planned to close our initial cortical analysis site-by-site results for meta-analysis beginning August 1st. And that's pretty much where we're at.